morning, everybody. My name is Deliens. I'm a medical sociologist from background, and I'm living in Belgium, which is a very small country in Europe. And actually, last Saturday, we had a big conference in Belgium celebrating 25 years of Palliative Care Federation in Belgium. Last week also, many of you have seen it probably, the new Quality of Dying Index was published. My country was listed number 5 on the list. Wow, great. But we are the first non-Commonwealth country in the world in palliative care. So you think we are doing well in palliative care after 25 years of experience in palliative care. So those of you think that we have established the perfect system of palliative care are wrong, completely wrong. There's many challenges in palliative care in my country and in many other countries in Europe. And so I think the WHO resolution also needs to tackle those countries and needs to be a policy driver for changes in the healthcare systems also in the developed countries in Europe and in the United States and in other developed countries. So I think we are not there, and there's many patients out there who are waiting for us, who are waiting for the policy developments to receive proper palliative care, and mainly among also non-cancer patients. But being a sociologist, I'd like to take you on a more cultural journey because we are confronted with really substantial changes in our culture in Europe and in my country. There's a growing impetus for people with long-term care conditions to take more control over their health. And there's an increased value being put on personal autonomy, and then and also on self-determination. And I'm also always thinking about my own education. When I grew up with my parents, it were my parents who decided for me what I had to eat, what I had to wear, what kind of clothes I had to buy, where I had to go to school. I have now a growing-up daughter of 16 years old. I don't even dare to tell her what to wear. I mean, just giving you just one generation of differences in cultural values and cultural orientation has a huge impact on our healthcare systems also. And we have to realize that. There's also more and more legal frameworks that support these switches in values. In my country, we have a law on patients' rights, we have a law on palliative care, and there's also laws in some of the countries on physician-assisted dying. But also the culture of the professional caregivers in our healthcare system is changing. Paternalistic attitudes of doctors, although still very much existing in many countries, but also other healthcare professionals to protect patients from bad news, such as diagnosis and prognosis of life-threatening disease, is culturally less accepted in my country and also in many European countries. And there's a growing openness about these issues, and doctors more and more value also in the decision-making, shared decision-making with the patients and with the families. But if we look at our healthcare systems, what are they focusing on? What are the medical schools focusing on during the education in medical school? We have healthcare systems that are disease-centered care systems. They are very highly specialized. If you're going to oncology, you don't meet a general oncologist. You meet an oncologist who is specialized in lung cancer, or you meet an oncologist who is specialized in another organ. Hospitals are, although they were developed over the last century originally as intramuros institutes for good care, they're becoming more and more what I call diagnostic factories. And I have many examples, old examples from 15 years ago, but also examples from just last week in my country of this kind of diagnostic treatment and over-treatment in hospitals. And I think doctors are also addicted to what I called, it's probably not a proper English word, diagnosticism. I don't know whether that exists in English, but you know what I mean by that. And if you compare what we are doing in palliative care, it's very much in contrast to these observations on our healthcare systems. We are delivering patient-centered care or person-centered care, generalistic and holistic care, and we are focusing on the quality of life of the patients and the families of it. And withdrawing and withholding treatment is something doctors don't learn at medical school, and is one of the key skills that a good palliative care doctor needs, and so also all doctors who are treating patients in the hospital need. So promoting palliative care in this dominant medical culture is very difficult. And in my view, as a sociologist, I think you need a cultural revolution to change that. So it's not a simple thing that we can alterate in the processes of our healthcare system. We have to go to the heart and the core of our healthcare systems. And that's very important. And if I reflect about the WHO and about the value of the WHO, I'm thinking about the cultural revolution that the WHO had initiated about changing the perception on health, changing from a negative definition of health to a positive definition of health. That was really a cultural definition. It had a huge impact on the policies that were developed throughout the world afterwards. And I'm talking now about the 70s and the 80s. And that's what I think we need also in palliative care. So we need the support of the WHO to really be ambitious on this and try to change the heart and the essence of our healthcare systems. And palliative care, I think, has lots of benefits, and also from the skills we have in palliative care, we can be key drivers in this changing of the healthcare systems. Changing the healthcare systems, I think we need to differentiate the meaning of palliative care. Palliative care is very often has a single meaning or had different meanings, and we need to be specific about. So we need to differentiate between specialized palliative care, generalist palliative care, which is a kind of skill that all primary care providers should have. So that means that it needs to be integrated in the medical school, in nursing schools, social workers, education, etc. And then the least developed, at least in my country, is the palliative care in the community. I mean, who is doing palliative care 24 hours, 7 by 7? It's the family carers and it's the volunteers. And so they need to be also integrated into the healthcare systems, and we need to develop models of collaboration with the professional care providers. So policy drivers and leadership for changes of our healthcare systems need a multi-sectoral approach. We need to involve research, education, practice, and community. So if you think about policy drivers and leadership in research, you can think about chairs in palliative care and chairs in palliative care research at universities, developing of research programs, establishment of multidisciplinary research teams, and developing of PhD programs. On the level of education, I think we need to integrate palliative care in medical schools, also in the postgraduate education for GPs or clinical specialists like oncologists or pneumologists or neurologists. And also we need to integrate it in other health and social care professionals. From the point of view of practice development, we need multidisciplinary approaches being developed within the healthcare system. Best practice promotion is very important, I think, to develop palliative care, but also the monitoring of the quality of palliative care, because we always believe that we are doing very good jobs, but I think we have to assess it, and we have to monitoring the quality of our services. Palliative care, of course, needs to be accessible for all patients and also independent in which setting they receive care. And one of the challenges in my country, if we know that, for instance, on average, palliative care is delivered 15 days before death in my country and 20 days before death for cancer patients. That is far too less, and so we need to develop much further earlier into disease trajectory this palliative care. Coming to the community development, I think we need the involvement, more involvement of the community. And there's many resources out there in the community that we just don't use and we don't integrate into our systems. But for doing so, I think we need really a broad intersectoral approach. So it's not only the employees who need to change their lives when one of their family members is becoming sick. It's also the employers who have to take up their responsibility within the healthcare system. And in my country, for example, we have palliative care leave that needs to be at least for a few months to be paid by the employers when people from the families are taking their leaves. But also we have to empower informal caregivers. I have plenty of examples in which informal caregivers are doing a good job, but the communication with the GP is very poor. And so there is no professional collaboration between the informal caregivers and the professional caregivers, and that leads to the contradiction of the empowerment of the informal caregivers. So I'd like to go to some examples, but I don't have time for all the examples, so I'll pick out one of the examples. I wanted to talk about a new policy document that we are preparing within the Royal Academies of Medicine in Belgium, but I will focus on a comprehensive approach in the Netherlands. So those of you who think there is no money for palliative care in Europe are wrong. I think there's money, and this program shows you that there is money. This is a new program for the further development of palliative care in the Netherlands. It's a program for 51 million euros for the coming years. So if all those European countries would allocate that kind of money to palliative care, we could maybe also allocate 10% or 5% to other countries in Africa or in Asia or etc. for the development of palliative care. So it's a program that will run up till 2020. It's a comprehensive program aimed at improving palliative care through 3 different sectors. So it's an intersectorial approach: education, research, and practice. It's a program that is run by the Ministry of Public Health together with the Applied Science Foundation in the Netherlands over a period of about 6 years, and they are planning to evaluate the program in 2021. The palliative care stakeholders over the last couple of years have prioritized 4 themes for this program. The first theme is awareness and culture. Organization and continuity of care is the second theme. Care innovations and quality is the third theme. And patient participation and support is the fourth theme. Interesting in this program is that it uses an integrated approach for innovation in palliative care in the Netherlands. So it's run through 3 different sectors, but the programs are horizontal. So they're going through the different sectors of society. And the calls that are out now are promoting those projects that are covering the 3 different sectors. So if you submit a project, it's very beneficial and it increases your chances to get the money if you have a project that is doing both research and education and practice development throughout the 4 priorities. It's a program on innovation and improvement of palliative care, and it's embedded in the national existing policy program of palliative care. And that's based on nationwide coverage of palliative care, running with regional networks of palliative care, and each regional network has at least 1 center of expertise in one of the universities involved in the region. And the national policy in the Netherlands is based on the focus of the needs and wishes of patients and their families, and it's always been, since 15 years now, been part of the regular healthcare system. So it's the GPs who are being educated to do the palliative care at home, and they have specialists in palliative care consultants who can support the GPs. So my take-home message is, if medicine, and you all know that, is sometimes curing the disease, it's often alleviating symptoms, but it's always supporting the patients and the family. Why is palliative care not a core competence of many in the healthcare systems? And why is palliative care not more prominent or important in the global healthcare system? I think we do need to aim at a paradigm shift in general medicine and not just trying to improve palliative care. Additionally, we really need to aim for a paradigm shift in general medicine in order to fully integrate palliative care into the healthcare systems. And global healthcare system reform is needed for the integration of palliative care in the regular healthcare system. For example, basic skills of all GPs, the integration in the curricula of the medical schools, the nursing schools, and for implementing supporting measures for caregiving at the end of life at home. And a lot of research also to create an evidence base for palliative care is also needed. Not about the relevance of palliative care, because we all know already the relevance of palliative care, but about testing of the effectiveness of the different models in different care settings and among different patient groups. Thank you.